Hello. Today we will be getting a refresher on the ePCR and going over some documentation practices. The goal of this training is to go through the major sections of the ePCR and refresh field associates of what is expected and required of their documentation. So a call is born. A citizen or medical facility calls into CMed. Our dispatchers use a set of questions, or ProQA, to make sure the proper resources are sent. Once the correct unit is assigned and goes en route, a call is generated in the ePCR server. The ePCR is routed to the crew based on the truck number and crew members signed in on the ePCR tablet. After the crew makes patient contact, they open the ePCR and fill in the necessary documentation. This provides a durable legal record of the patient encounter and is used for medical, quality, and billing purposes. When the crew is completed with their necessary documentation, all crew members review and sign the call. After crew signatures are gathered, the call is signed off using the crew-specific passcode. The call is ready to be sent to the server for processing by QA and billing. Billing will verify the information and signatures on the call, then place it in a specific category based on the level of care and treatment provided. If all the correct information is present, the call can be billed to the patient's insurance company. The sooner we get all of the information verified and sent to the insurance companies, the better our chances of receiving full reimbursement for the services we provide. If all of the information or signatures are not present, then the call is audited through the QA process and returned to the crews for correction. We will discuss this further in the presentation. There are times when we randomly audit calls to ensure that we're providing the most complete and accurate information on our ePCRs as possible. With over a full year of ePCR data, we are seeing great strides in our documentation practices and also areas that we can always improve upon. Specifically speaking of the ePCR tablets and their connectivity, please make sure to fully reset your ePCR tablet at the beginning of each shift. This will ensure that the machine is refreshed and ready to go. When not in use, the ePCR tablets need to remain connected to their charging cord. Make sure that the tablet is connected to a work location and to your correct truck's Wi-Fi. If you are not connected correctly, it can cause delays in receiving your calls and could lead to lost or corrupted information. If possible, this needs to be verified prior to shift start and resolved before the crew leaves the station or runs a call. If you experience any extended loss of connectivity, please make sure your direct supervisor is made aware. If they are unable to resolve the issue, please put in an ePro IT incident report to ensure we track and repair any issues as soon as possible. If there are calls outstanding that cannot be saved to the server, the crew's immediate supervisor needs to contact our mobile IT department. Now that we have ensured that the tablet is connected properly, open the ePCR program. The login screen will ask for you to enter your name and passkey. Please make sure that you have a globe at the bottom right-hand side of the screen showing a green plus sign. If you are showing a blue exclamation mark, then you are logged on to another tablet or the tablet is still connecting to the server. Depending on connectivity, it could take a few minutes for the tablet to connect to the server. If you have a red X, then the tablet is not connected to the server or the internet. On the main screen, select the Current Crew button to set up the crew information for your shift. Make sure any crew or truck swaps are updated in this section. Click Add to set up the crew. A warning will come up stating that the person logged in must be a crew member on the crew information. Make sure that the shift start date, vehicle number, and crew members are correct. Select OK when complete. Make sure the information you entered is highlighted and select Set as Current to continue. If you are properly connected, the current call will generate in the bottom half or pending PCRs portion of the screen. Click on the call and a blue check mark will appear beside it. Click on Request PCR and the call will be moved to the top half or inbox portion of your screen. You can then open the call and fill in the appropriate information. If there are connection issues or a dispatch call does not show up on the bottom of the screen, do not panic. Click the New button at the top of the screen to generate a blank ePCR. This PCR will not have any dispatch, mileage, or times filled in. They will need to be manually entered. There will be times when connectivity is limited and you do not receive your dispatched ePCR. Do not panic. Start a new PCR. Once completed, save it to the server until the dispatch copy comes through. It will show as validation required. You can then pull up both calls, highlight them, and select Merge. Warning: merging is not able to be undone. If you merge the wrong calls together, your correct information may be lost. If the dispatch call does not come through, it could be that the crew information is not correct. Check dates and truck numbers. It could also be due to the call being reassigned and the original crew opened the call prior to patient contact. In either case, the call will be merged on the server side by management. If any issues still exist after merging, the crew will be made aware. The first screen is your trip screen, and that has dispatch information first. Make sure the information listed in the ePCR is correct. Let dispatch know if the pickup location is incorrect. We can update it on the ePCR side, but if dispatch is not aware, the information will remain incorrect. This causes issues in verifying information for billing, and documents or bills from MGA may be sent to the wrong location. Times will be filled in by the connection to dispatch and the information recorded by the navigator tablet. Please check for accuracy. Mileage will be updated by dispatch based on the information from the navigator tablet. Please check for accuracy before completing your call. The scene screen addresses any scene issues such as how the patient was found, location type, number of patients, and any scene delays. It is extremely important to confirm the patient's information with the patient. If you list the hospital as the patient's address, then that is where the bill is sent. This can delay the reimbursement process immensely. Phone numbers are extremely important. If we do not have a valid phone number, then we will be unable to verify important information with the patient. As a rule, list as much information about the patient as possible. Any responsible party information should be recorded on this screen. Insurance and employment status are documented on this screen. If any workman's comp information is present, fill in the information at the bottom. For insurance companies, click the Add button to add each insurance provider. Please include as much information as possible, and be sure to take pictures of the insurance cards listed if available. This screen is where the crew uses their assessment to document whether the patient meets medical necessity. Let's discuss a few of these topics further. bed confined status is the inability to get up from bed without assistance, and the inability to ambulate, and the inability to sit in a chair, including a wheelchair. All three conditions must apply, not one, not two, but all three, and the narrative should support these findings. Clues to the patient's normal status can be a jerry chair being present versus a wheelchair, turn schedule, or other items in the room that would only be necessary for those that cannot move by themselves, such as a Hoyer lift. Posturally unstable. The patient cannot walk without assistance. This includes use of a cane, walker, or the crew holding the patient steady while walking. In the pictures below, the elderly female having two firemen assist her is someone who is posturally unstable. The female walking around a jogging track would be stable. Was sitting contraindicated? Did the patient have a decubitus ulcer or other reasons they could not sit in a wheelchair? Did the patient not have the balance or stability to sit upright without falling over? Remember, a jerry chair is not a wheelchair. It is designed to recline the patient in a semi-seated position. These are used in skilled nursing facilities and dialysis centers. The patient on the left is secured in a jerry chair with straps to keep him from falling over. The patient on the right is secured with straps in a wheelchair to keep her from falling over or falling forward. With the CERT CMS section, we need to avoid conflicting information with the narrative. This could be an example of documenting the patient was able to walk without assistance, but the CERT CMS question of bed confined was marked yes. Those are two conflicting pieces of information. The CERT CMS information should be based on the crew's assessment, not the physician certification statement. Remember to accurately document the patient's condition at the time of transport. Back to the ePCR. Chief complaints can be recorded on the chief complaints screen, and they can be selected from the list on the right. Please denote which complaint or complaints are primary and document the duration of these symptoms. List the cause of injury if applicable. If no injury, be sure to select none. Please list any and all past history on the patient. There is an other option to type in a condition if not listed on the right. Please list any and all medications for the patient. There is an other option to type in any medications that are not listed on the list to the right. Please list any allergies for the patient. Like said before, there is an other option to type in any allergies that are not listed on the right. No known drug allergies is available if no allergies are present. Please list the location and organ system of the chief complaint. A condition that affects the entire body will be listed as general or global. Document the primary symptom if applicable. List who the medical history was obtained from. For female patients, document if they are pregnant or not. For male patients, this field must be documented not applicable. On this screen, you can document the mechanism of injury. If no injury, document not applicable. This screen allows you to document a full head-to-toe assessment starting with the critical systems. The body survey is very detailed. If you are unable to find the specific issue on the list, use the Annotate feature to draw or write on the part of the body that is affected. Please use appropriate drawings and verbiage. Once completed, select Done. If your patient has an isolated complaint or no physical complaint, document what the issue is and then select Auto Mark. This feature will allow you to mark all of the undocumented fields as not assessed or within normal limits. Make sure to document any pre-existing issues such as amputations or contractures. On this screen, you can list any applicable impressions of the patient. On the trauma screen, you can document any trauma categories, and these are for that small percent of patients that actually meet a certain trauma category. This screen is for any contributing factors to an injury. If no injury present, select Not Applicable. For cardiac arrests, fill out as much information on this screen as possible. For the vital signs screen, click the Add button to put in sets of vitals. Remember, all transports require at least 2 sets of vital signs. This shows that the patient was monitored from point A to point B. When entering any interventions, there is a quick log for certain patient types. Select the Category button to see all the types available, such as cardiac arrest, chest pain, stroke. We have listed the common treatments for the various patient types. If you do not see the intervention you performed, select the Interventions button for a full list. Interventions are categorized on the list to the right. All interventions must be documented here, including CPR, oxygen, cardiac monitor, 12-lead EKG. Yes, cardiac monitor and 12-lead EKG are 2 separate interventions. Any extrication, ROSC, any IVs, IOs, any airway attempts, or any medications given. Remember, if you did not document it, then it did not happen. The Outcome screen allows you to put in various transport information, including response type, patient disposition, protocols used, how the patient was transported, and to where. Be sure to check for correct transport priority and check for the correct destination. These are extremely important in processing the call. The Time screen here is linked to the one in the Trips tab. Please review for accuracy. On the Signature screen, please note that the signature types are very close together. Make sure to double check you have selected the correct signature type before the patient or anyone else signs. A signature captured under the wrong signature type could be invalid. Let's discuss these signature types in detail. Signature type A is for the patient and no one else. Signature type B is for any responsible party, and this is when a patient is unable to sign for themselves. If they are not feeling like signing or would rather someone else sign, please remind them that without their signature and they were conscious and alert, then they will be billed directly and we are unable to bill their insurance if they do not sign. If they are unable to sign, please make sure that there is a reason unable to sign. This must be listed and supported in the narrative. Signature type C is for the crew. This is a very common one when the patient is unable to sign for themselves and there is no responsible party available. The crew member must sign their name, attesting that there was no one available to sign the ePCR on the patient's behalf. This is not accepting responsibility for their bill. This is simply the medic stating that at the time of transport, no one was available to sign for the patient, including themselves. We also need to list the reason unable to sign. This must be listed and supported in the narrative. A receiving facility signature must be obtained on all transports. A transport of a patient to their home must have a patient signature and a receiving facility signature. It is all right if the patient signs as the receiving facility if the destination is their residence. For skilled nursing facilities, please make sure you get an RN, LPN, CNA, or sitter to sign as a receiving facility. Refusal of treatment and transport must be obtained if a patient refuses all treatment and transport. It is not designed for patients that refuse part of your care and accept transport. If a patient refuses a treatment, clearly document it in the narrative and include your advice to the patient, encouraging them to accept the treatment. Now back to the ePCR. This screen allows for the crew to sign the call. Make sure the date is correct and the vehicle number is correct that's listed. The time summary allows you to look at the timestamps for transport along with any interventions and assessments performed. Please review for accuracy. The next section of the ePCR is the narrative. Let's take a few minutes to look over the D-chart method to help fill in all of the necessary information required in our narratives. This information should be gathered on any patient contact regardless of transport. Dispatch information. For example, Unit 572 responding to a respiratory distress. The next letter is C for complaint, along with the age and gender. For example, crew arrived to find a 57-year-old female with difficulty breathing. This includes how the patient was found. For discharges and pre-scheduled transports, please list why the patient was in the hospital. This information is extremely important. The next letter, H, is for history of present illness and pertinent past medical history. For example, patient states that the respiratory distress has become worse over the past hour. She has a history of asthma and hypertension. A in the mnemonic stands for complete assessment. For example, patient in mild respiratory distress. No accessory muscle use or cyanosis present. Lung sounds are clear in the lower lobes, with some wheezing in the upper lobes. No JVD or edema present. Head to toe otherwise unremarkable. Make sure to clearly document any distress presented by the patient. The R in the mnemonic stands for care and treatment by EMS. For example, crew assisted patient to stretcher, assessed vital signs, and loaded into the ambulance. Blood glucose level assessed and within normal limits. INT established in right hand with normal saline flush. Patient given 1 albuterol and 1 ipratropium bromide mixed updraft treatment, resulting in the relief of symptoms. Patient medically monitored during transport. This includes how the patient was moved to or was placed on the stretcher. Include any stair chair use. Please make sure that you note the patient was medically monitored during transport. This does not necessarily mean cardiac monitoring. It means that you monitored the patient's vitals from point A to point B. The T in the mnemonic is for transport or non-transport information. For example, transported patient to hospital ER per request. Advise staff of patient condition and upon arrival place patient in room 12 and assisted patient to ER stretcher. Report given to RN Doe. Patient able to sign for herself. No further changes during transport. Make sure to document if the patient could not sign for themselves and why. The E in the mnemonic stands for exceptions. If protocol treatments were contraindicated, document why. For example, your 52-year-old male was having chest pain and you did not give aspirin because he had already taken 324 milligrams prior to your arrival at the scene. If extended time on scene, document why. For example, your 36-year-old female patient is morbidly obese and is located in the back bedroom of a narrow hallway with clutter. Was medical control contacted for orders? Why and what was the reason? For example, your 13-year-old 45-kilogram male patient is experiencing persistent wheezing and you contact medical control for 1 gram of magnesium sulfate. Other exceptions. Did the patient refuse any treatment or transport? For example, you ended up transporting the patient, but they initially refused, delaying you on scene. The patient refused being placed on a long spine board, but agreed to a C-collar. Document any advice or cautions communicated to the patient if they refuse treatment or transport. Statements like, "You may suffer serious harm or death because you refuse this treatment," is appropriate to document in your narrative. So back to the ePCR narrative screen. The D-chart narrative can be listed out like this. I prefer it, it's cleaner. You remember each portion whenever you fill it out. Or can be written out in typical paragraph form. All the same information is there, it's just all pushed together and you could forget something, so it's your choice, the list or the paragraph form. The narrative screen has a spell check option. Please use it. It will not catch the wrong word being used, such as whale instead of while, but make sure both crew members review the narrative prior to completing the call for any mistakes or missing information. The ePCR tablet has front and rear facing cameras, great for taking pictures of documentation. Any paperwork should be photographed and attached to the call. This includes IDs, face sheets, insurance cards, physician certification statements, airway forms, and any other necessary medical paperwork. Select the camera utility, and then in a well-lit area, place the paper document on a flat surface and hold the tablet square above until it is fully visible on the screen. Carefully take a clear picture of the document. Using the Attach button in the ePCR, add the pictures from the tablet to the correct call. Pictures will be erased periodically for security purposes, so make sure that at the time of the call you attach the proper photos. All paperwork must be labeled with the run number at the top of the document and turned in at the end of the shift. Do not leave unattended paperwork in the ambulance. All calls that result in a transport to an ER must have a face sheet. On all Priority 5 calls, make sure a PCS is completed by the sending facility. If one cannot be obtained, please make sure you document why in the E part of your narrative. Remember, the PCS is the facility's assessment of the patient. Your assessment and CERT-CMS questions are completely based on what you and your partner observe of the patient. Complete call rules are different for each patient and transport type. If you continue to get a red X and cannot resolve the issue, please write down the error and put in an ePro IT incident report to ensure we track and repair any issues as soon as possible. As discussed at the beginning of the presentation, there are times when all of the necessary information or signatures are not collected. This poses a problem for billing, and correction of documentation errors or clarification of vague documentation must occur to seek proper reimbursement. Calls are identified by billing and placed in a special queue. Common issues for calls being returned are no reason listed in the signature language or narrative why the patient could not sign for themselves, conflict between the CERT-CMS questions and the narrative. For example, patient moved by draw sheet in narrative, and all CERT-CMS questions are listed as no. These facts conflict. Wrong signature language used. For example, patient unable to sign listed in signature type A when it should be listed in signature type B if a responsible party is available, or signature type C if no responsible party is available. Every day, the calls in the queue are reported to the Director of Clinical Education and Performance Improvement for review. The Director reviews the calls, sends them back to the crews with instruction as to what needs correction or clarification, and it's listed in the workflow comments. These comments can be viewed in the Pending PCRs or Inbox section of the ePCR program. The operations managers of each division are notified of the calls in their areas that need review and are instructed to make contact with the specific crew members to ensure they are aware of the return calls. Once completed, the Director of Clinical Education and Performance Improvement reviews the calls for accuracy and sends them back to billing for processing. This can be a very tedious and labor-intensive process. As you can see, it is very favorable to document accurately and clearly the first time around. Remember, the ePCR is all anyone has to refer to after the call is over. Take the time to review, correct, and review again to make sure the call is a representation of the great care that you provide. Thank you for the great work that you do every day.